And welcome and thank you so much for joining us today for day one of the Opioid Industry Document Archive's 2026 Symposium. My name is Caleb Alexander. I'm a professor of epidemiology and medicine at the Johns Hopkins Bloomberg School of Public Health. And on behalf of the entire OIDA team, we're so glad you're joining us for our third national symposium. Again, please note that this is being recorded and links to the recording will be posted on our website and shared to our email distribution list. Next slide. Before we begin, I just want to note that I have served as a paid plaintiff's expert in federal and state opioid litigation. There are no other disclosures to report for today's speakers. Next slide. The Opioid Industry Documents Archive, or OIDA, is a groundbreaking digital archive of documents arising from the opioid industry that advances understanding of the root causes of the opioid epidemic and helps to address corporate behavior that is harmful to public health. Winner of the Society of American Archivists Archival Innovator Award and co-directed by the University of California, San Francisco and Johns Hopkins University, OIDA has now reached a milestone of more than 7 million documents, representing more than 33 million pages. The documents include emails, memos, presentations, sales reports, budgets, audit reports, DEA briefings, meeting agendas and minutes, expert witness reports, and depositions of company executives. The archive serves as a living repository of information that can be used to learn from the opioid epidemic so as to improve and safeguard public health and public policy, and to ensure that opioid-related harms that have taken place never occur again. Next slide. OIDA was created and funded in part through settlements of public interest lawsuits by states, and we'd like to acknowledge the millions of Americans who have been personally impacted by the crisis, as well as to recognize the attorneys general and many other parties whose vision and commitment to transparency and accountability has made the archive possible. We strive to ensure that OIDA serves as a trusted source of information to help people understand the crisis. We're developing this digital archive and it's supporting resources for the benefit of the public, including individuals, communities, researchers, journalists, policymakers, and others affected by the crisis. OIDA and its services are freely available for all. I'd also like to thank Kevin Hawkins and Amanda Norman, members of the OIDA team who've worked especially hard to organize this year's symposium, as well as my counterpart at UCSF and our colleague, Kate Tasker, and the broader teams at UCSF and Johns Hopkins that are responsible for the archive's enormous reach and impact since its inception only a few years ago. Finally, I'd like to thank all of you and all of the speakers who are participating in this year's symposium. Next slide. The OIDA team has created, and continues to create a number of resources to help with further exploration, teaching, and mining of the archive. For example, in recent years, we've introduced an opioid crisis timeline, a curriculum library, a data toolbox, and the OIDA image collection. These resources, as well as our research guides and recently released curated document sets, provide archive visitors with footholds, with tools for research and data analysis and other forms of exploration and discovery. Next slide. Indeed, there are many stories to tell from the opioid collection. From marketing tactics to abatement strategies to policymaking and much, much more, we expect the archive to support research looking back at the crisis and helping to formulate systemic change to prevent future harms to public health. Next slide. During our first hour, we'll have a presentation by our keynote, followed by a question and answer. Then in the second hour, please join us for presentations by two more very distinguished speakers, followed by a discussion moderated by Pamela Ling, Professor of Medicine and Director of the UCSF Center for Tobacco Control, Research, and Education. Next slide. Pam will have a chance to tell you a little bit more about the speakers and the discussion that she'll moderate. And so I'd like to turn now to our keynote. And we couldn't be happier, Brian, to have you here. We thank you so much for taking time out of your busy life to join us. As most of you probably know, Brian is NPR's first national addiction correspondent. He also covers breaking news in the US and around the world. Mann began covering drug policy and the opioid crisis as part of a partnership between NPR and North Country Public Radio in New York. After joining NPR full time in 2020, Brian was one of the first national journalists to track the deadly spread of the synthetic opioid fentanyl, reporting from California and Washington all the way to West Virginia. After losing his father and stepbrother to substance use, Mann's reporting breaks down the stigma surrounding addiction and creates a factual basis for ongoing national discussion. Brian's also served on NPR teams covering the Beijing, Paris, and Milan Olympics and conflicts in Ukraine, Israel, and the West Bank, topics that we won't be covering today. During a career in public radio that began in the 1980s, he's won numerous regional and national awards. He's also author of a 2006 book about small town politics called Welcome to the Homeland, described by The Atlantic as, and here I quote, one of the best books to date on the putative red-blue divide. Brian grew up in Alaska and is now based in New York's Adirondack Mountains. His audio postcards, broadcast on NPR, describe his backcountry trips into wild places around the world. I will turn things over to you now, Brian, but I'd like to note for all of you that have joined us, we do have a question and answer function, and that's open and available even now. So please feel free to submit questions. Brian and I have discussed that we'll have a substantial amount of time for discussion. So, Brian, we couldn't be happier with your joining us, and thank you so much. And look forward to engaging with our full audience this morning and this afternoon regarding these matters. So the floor is yours.
Thanks very much, Caleb. I appreciate your having me. It's an honor to be here, and I always forget that that's my promo photo that NPR has, and the first question people are going to have is what happened to all my hair. I need to update that image. Um, I'm grateful to be here. When I was invited, I had to kind of think about whether I felt like I was the right person to be involved in this conversation. There are so many powerful journalists who have guided me and who have really led the way with strong data-driven reporting. And I guess one of the things that made me feel a little more comfortable about sort of jumping into this conversation and being part of it is the fact that, as you mentioned, before I came to NPR, I was a station reporter. I was a local journalist, really for most of the time that I was covering addiction policy, drug policy. And I think that experience gave me a really healthy sense for the challenges of this kind of storytelling, the difficulty to get your mind around the scope and the scale of a public health crisis like the one that we've all been experiencing with opioids. And so I'm going to talk about some of that kind of personal journey. I will say that in preparing to talk today, I just happened to be in Stamford, Connecticut, last week for a public event, and it had completely gone out of my mind that that was the headquarters of Purdue Pharma and now NOAA Pharma. And so it was kind of a surprisingly emotional event to stand outside that building and sort of be there and thinking about this conversation today and the way that the archive is sort of memorializing and bringing forward a lot of what that company and others did. Um, Let me say again, to sort of stay with the, you know, I guess somewhat emotional thing. I think one of the things that I like to say when I talk about this reporting is it is important, I think, to remember the magnitude of what we've just experienced. A lot of us, when we're reporting day to day, telling granular stories, or researchers I talk to, even frontline public health people get caught up so um, understandably in the challenges of the moment of helping one person survive, helping one person move toward healing, one report that they're working on, one public policy debate that they're in the middle of. I think it's easy to lose sight of the fact that this really is a devastating scale of death and loss. We have seen communities shattered in ways that never happened before with addiction in the United States. Um, and the fact that so many of our public institutions were factually complicit in that, um, which again is one of the really fascinating elements of the archive, I think heightens the sense of this. And so that's part of what I want to talk about here. Um, and before I start in my list of kind of comments that I want to run through, I do want to again say, please do sort of sketch out questions. It'll be funner for me when we get into more of a conversation. So my personal journey, again, as Caleb mentioned, did start with deep and very painful addiction in my own family. My father, poly substance use. My stepbrother Rick passed away from medical complications linked to his long-term addiction. He was first prescribed OxyContin while working in a paper mill in the Pacific Northwest. Um, and I often talk about that, but the reason I mention it in this setting, it's a little bit different. It's because it was the first taste that I got of the lack of information, the lack of public health information, and even what feels in hindsight like secrecy or an unwillingness to educate even families who were involved in this. We were experiencing addiction on a daily basis, and we were, around doctors, we were around public health people, we were around law enforcement. And what we heard was stigma. What we heard was discussion of criminality. What we did not hear through all of those experiences was the idea that our loved ones were falling into a pattern of unwellness and into a public health crisis pattern that was increasingly well documented. And as I've moved into reporting on this, that gap has felt urgent to me. The fact that so many people in the public, so many families who are experiencing this immediately, it's still very difficult often, without stepping into the very balkanized, kind of ghettoized world of addiction. It's difficult to get real-time, good, science-based, caring information. And that feels increasingly deliberate to me as I sort of follow my career forward. The next step for me, when I was a station reporter, I moved to the Adirondack Mountains here in upstate New York. And the first year or two that I was here, I did a lot of soft and fuzzy reporting about the beautiful mountains and the rivers and hiking and tourism and all of the things that make the Adirondacks kind of famous. And it was very slowly that I realized that tucked away back in those valleys was this incredible constellation of state and federal prisons. And those state and federal prisons were filled with massive numbers of mostly Black and Hispanic men who had been incarcerated on mostly crimes related to addiction. And what I learned was, again, there was this very deliberate divide between addiction policy that was embroiled in the economy. It was embroiled in jobs. There was a very conscious act of using mass incarceration linked to drug policy very explicitly. This was not something that had to be intuited. It was said clearly, these are going to be jobs for rural white people, incarcerating these people with addiction related problems in their lives. And at one point, and this is a bipartisan event, Mario Cuomo, who was one of the architects of this archipelago of prisons, he actually, when voters voted down the creation of this system, Cuomo actually reached into a state authority that had funding power that was supposed to be in existence to help fund urban development and urban economic activity in New York cities. And instead, he diverted that money to build these prisons. And again, while it was clear what was happening, by the time I arrived in the late 90s, early 2000s, there had been this disconnect between the public's awareness and the existence of this drug policy related industry. There was a point when a big report was released, basically profiling this region's economic activity. Where are the jobs? Where is the investment? Where's the public and private sector? And prisons were completely invisible in that document, even though they had become the single largest employer in the region. And so again, lack of clarity, lack of information, verging at times on a level of secrecy. And that brought me reporting on those prisons, reporting on, Rockefeller and Nixon era drug policies that created the mass incarceration era for addiction. That led me to starting to work with NPR, first as a station reporter, and then eventually on staff as the opioid crisis was really accelerating, and as we were beginning to see greater and greater degrees of harm. And we were beginning to see um, much more clearly that in addition to this kind of economic public sector, private sector link around mass incarceration and economic drivers, there was also this growing impulse around corporate production of opioids, corporate marketing of opioids. And of course, what we now know, in large part because of the archive and documents that were released through years of very difficult litigation and a lot of great reporting, um, we now know that not only did many of the largest corporations in the world, and certainly many of the largest corporations in the United States, um, throw incredible amounts of corporate power behind loosening regulations, easing controls, um, fueling this opioid crisis with uh, an incredible amount of energy. But there was also this deliberate effort over many years to maintain secrecy around those activities. Um, we now know that it was a standard practice. And I remember coming across this in roughly 2019. Other journalists were there far ahead of me, and I want to continue to just nod at that. But in 2019 was the first time that I became aware that a standard piece of settlements between corporations and state or federal prosecutors investigating opioid related misbehavior. A standard part of the settlement plan was secrecy. They would literally package up and return documents. They would destroy documents. They would keep them secret. And I think it's clear in hindsight that that lack of disclosure, um, that lack of public information that literally public officials had in their hands, and failed to disclose to journalists, to disclose to the public, um, if that information, even if the government was not more aggressive in prosecuting or bringing, much more powerful civil litigation at that point, if they had simply let us see what they knew. If we were allowed to see what the DOJ knew and what state attorneys general knew in the early 2000s, I don't think there's any doubt that it would have saved lives. Um, and we know from the documents that have been released and that are sitting now in the archive that while the secrecy was happening, with the collaboration of regulators and law enforcement, um, corporate America was also aggressively misleading the public about their activities, about the safety of their products, about their marketing practices. From McKinsey to Purdue to Johnson and Johnson, while none of these firms have admitted wrongdoing, they've all agreed not only to disclose documents now, but also to, pay significant financial settlements because of that past behavior. Um, I think that what that adds up to, we live in a time as a journalist. One of the things that I cover on an almost daily basis is the loss of trust in our public institutions, in science, in, whether it's vaccines, whether it's the medical community. Um, and I think sadly, but also factually, a lot of that is fueled by this event. Many of the institutions that were supposed to be not only on guard duty, but also we're supposed to be informing us publicly, telling us as family members, as people trying to understand this ravaging public crisis that was moving through our communities. What's the best information you have? What should we know about how this is vectoring? And instead, it was kept secret. It was minimized. Um, Accountability was kept to an absolute minimum. I want to mention as just one piece of this. This is often something that's come up in my reporting. While we talk about um, corporate activity, the federal regulators, the law enforcement, the DEA, the DOJ, I think another place where this lack of accountability has been powerful is in the medical community itself. I think that we know that some doctors drove pill mills and some doctors overprescribed, but I think another piece of this that is still underreported, and there's still not enough public documentation, is how and why so many physicians have refused, even after the elimination of the X waiver and the elimination of other kinds of red tape, they've refused to treat addiction as in many cases, especially when it comes to opioids, as a highly treatable illness. I think this is another area where the crisis of trust and the crisis of transparency continues. Um, and I think that that's something that I think, we need more reporting. We need a lot more public information about. One of the things that I think the creation of the opioid industry documents archive marks is a very hopeful, this is again, I think this is a very dark chapter. And I think it's sometimes, again, we can lose sight of just how, um, you know, we were, we were at a point where we were losing 110 plus thousand people a year. Obviously, those weren't from prescription opioids, but I think there's no doubt that the prescription era, at least, opened the door to what's come since. Um, but I think there is daylight, there is sunlight, there are things that have happened recently that show that public policy can work, that there can be ways of establishing accountability and at least somewhat more transparency. And the documents archive is a piece of that. And I remember when it was being discussed and debated. First of all, I was somewhat skeptical. I was skeptical that corporations would agree to this. But there were public officials who lobbied intensely in favor of this being part of the larger settlement. And I think it's mattered. I think it has really been part of something of a cultural change that many of these companies, I should say, were forced to or pressured to release these internal documents. I think um, we've seen that has mattered on some level. Um, and I think that's very, very important. I like to think um, that it has signaled to many companies that in the future, when they engage in this kind of internal behavior, um, that the potential for future revelations on this kind of scale and with this level of granular detail is possible. And I think that at least the archive has put a kind of chink in the armor of, the sense that this kind of thing could be swept under the rug and could be disguised almost in perpetuity. Um, I think that going forward, one of the things that's going to be very interesting to me in my own work, but also watching other journalists will be to see um, how well the archive serves. Um, Caleb mentioned the idea of looking back. And I think that's one of the questions that I'm going to have is how much, we've seen recently how powerful the Epstein documents have been. Those often are quite a big chunk of time back that the Epstein documents were created, and yet they've been very relevant to the current and future, reporting and tracing, which corporate executives are where and who was involved in what way. And I think a similar thing could be very, very interesting for the opioid industry archive. We have seen at an executive level so little accountability. So many of these folks who were making decisions, who were agreeing to internal policies at these companies, they continued to get their bonus checks. They continued to move up the corporate ladder. They've continued to have really successful careers. And so I think that's going to be one of the things to see whether the disclosures in the archive continue to cast some light on, who is still making big life-changing decisions in the U.S. healthcare system and how many of them are in these documents. I think that'll be interesting for people to explore. I love that there are still documents arriving and that's going to be interesting. I also I'm also going to be interested to see if over time the archive has ways to do mechanisms that keep new information coming in. Obviously, this opioid crisis is evolving very quickly, and there are also many pieces of this, even the past crisis, whether it's the regulators or the law enforcement agencies, there are many of pieces of that that we do not yet have great disclosure and great clarity on. And so I think that's really important. I think it's going to be, I guess my point with this is it's going to be very interesting to me in my own work, but also with other journalists to see the degree to which the archive is a snapshot of a point in time, a big point in time of the opioid crisis, or whether the revelations there continue to be living and updated and kind of carry us forward. I want to say one last broad thought as I was thinking about the archive and going back and looking through details of it, preparing for today. Um, I guess I had one last um, somewhat emotional response to what I was seeing. The United States, we're a society that we memorialize everything. There are statues. We fight over our statues. We fight over the plaques on the walls, what's going to be up in the school, whatever. But one thing we do not memorialize is public health crises. In many of the small towns that I'm in, you literally still see World War I memorials. You see Civil War memorials. What you don't see are Spanish influenza memorials or, a memorial to the tobacco era. You know, COVID. I spent a lot of time in Lower Manhattan, and there's the amazing 9/11 memorial, but there's no place that I know of in the United States where there's a COVID memorial where we gather as a community to remember um, the incredible losses, but also the incredible work and service and sacrifice that people made through those public health crises, keeping people alive. And that feels especially poignant to me in this opioid history, that there is this thing that happened because of human activity, because of human profit making, human corporate structures, breakdowns in systems. And on the other side of that equation, there has been heroic effort and sacrifice and effort to keep as many people alive and move as many people towards recovery as possible. And yet, again, correct me if anybody knows of this, there's no place in the country where there's a fountain or a park where people can gather, I know things pop up and there are sort of days when people put gravestones out or whatever. And so I guess in looking through the archive, I had a reaction that I felt like that's kind of what I was seeing here. It's not exactly the same thing, but the fact that there is a place where people can go back and look and see the images. The image archive is very powerful. They can see these documents. They can see the chronology of how this hit. Um, it is, in a virtual sense, it feels like an important memorial to me, like a place where, we can kind of see um, the magnitude. We can see the culpability. Um, we can see the questions it raised about the structure of our society, which is, I guess, what memorials do. They make us think, how did that big event in our society happen and how did we react to it? Um, and so I guess I think that the opioid archive has a practical purpose. I think it will continue to serve accountability and answering questions about corporate involvement in addiction and larger questions about drug policy. But I guess I feel that it's also symbolically important. It was a victory for sunshine. It was a victory for transparency. And as of this moment, it's one of the most clear memorials for this devastating event that we've gone through. So I'm incredibly glad that it exists. It feels important to me, and I will certainly be spending a lot more time sort of rooting around in it as I go forward with my own reporting. Um, so with that, I will hand it back to you, Caleb, and see if you have questions or if anyone else does.
Great. Thank you so much, Brian. I mean, we would have a day or a weekend or a month of things to talk about based on those comments. And I do want to remind everyone the question and answer function is open. Nothing will make me happier than seeing lots and lots of questions come in and points of discussion, reflections. I know there are a lot of journalists in the crew, although we probably also have some health law and health policy experts. And I imagine we also have many people that have lived experience, may be bereaved, may have personal experience with addiction or overdose. One doesn't have to go far, of course, to for that to be the case. So please, thank you so much to those of you that have added questions. I'm going to ask one of my own, and then we'll come to some of those that have been posed. But this was really terrific, Brian. I guess I was curious first. You mentioned wanting to acknowledge amazing journalists that have come before you. I'm not asking you to name names, but I do wonder if you might just say briefly a little bit about one or two people, who you hold in high regard that have done reporting in this space. And again, not necessarily looking for the name of an author, but just wondering what it is that you think has allowed for some people to make really such formative contributions to our understanding of the epidemic.
I guess what I would say is that it was the Washington Post team that really worked on a lot of this. I won't single out names there, but they were really in the lead, I think, through a lot of it in terms of doing data mining on, where a lot of the opioid distribution happened, the scale of the opioid distribution. I absolutely drafted on a lot of the revelations that they had. Folks at ProPublica were, you know, leading the way, the New Yorker. And as a station reporter, I can remember again being in my little regional bubble and seeing things and just, and I think this is part of what we saw for so many years was that the way that institutions spoke about this was very balkanized. It was very much, different, areas without pulling back the lens and helping us understand the scale of this. And I will say, this area is only one part of the larger as a journalist, I think about tells, like things that seem to really reveal a pattern that's like there's something here that's worth probing. And one of the things that's a real tell about addiction policy is that so much information is so hard to get. It's not just
Yeah,
corporate documents, it's not just the DOJ, it's basic data. Like
right,
what substances are vectoring in what communities at a given time. We knew, I know this is not an apples to apples comparison, but we knew within weeks where COVID was almost on a house by house basis. We're
right.
decades into this addiction overdose crisis, and we still are months behind in knowing what's, killing people in Baltimore or killing people in San Jose. And
Yeah,
the fact that we can't mobilize better to get better data, real-time public health data is a tell to me. There's something
yeah,
about drugs and addiction, and the overlap with law enforcement, the overlap with other social issues that really just makes this a very difficult space. Um, and as a
yeah.
local reporter, I often found that almost impossible to overcome. So other journalists really led the way on some of that.
Yeah. Well, I thought your discussion of the prisons is really compelling, and in some ways, it's sort of like hidden in plain sight. And, it made me wonder about other sequela of the epidemic in other communities that might be analogous, homelessness, excuse me, predatory treatment facilities. There are lots and lots of sort of ripple effects of the epidemic. And here you were living in New York, and if you drive around a lovely lake in the Adirondacks, you might never know that sort of 3 miles beyond is a massive facility that holds incarcerated people, as you said, many of whom are there because of addiction and use disorders. There's a question from someone, and I'll just read it verbatim because it's also about sort of the hidden costs of the epidemic.
Mhm.
Someone wrote, Brian, thank you for your work. I've been listening on NPR since the beginning. I represent Generation O and the children born from women who used opioids during pregnancy. Research shows opioids can alter fetal brain development, yet public attention ends after their withdrawal at birth. In 2023, we lost nearly 95,000 people to overdose, and another 95,000 opioid exposed children were born. Caregivers are raising these children with long term challenges involving regulation, learning, sensory processing, and behavior, but their voices remain largely absent from the national conversation. What will it take for media, policymakers, and projects like OIDA to fully recognize these children and their families?
Yeah. Um, I'm working on a project right now that actually is about the intersection of addiction and women who are pregnant up to 1 year postpartum, which is an incredible period of vulnerability for them and for their children. And obviously, there are huge implications for young people who are born exposed to substances. I think that this is an area where there obviously needs to be a lot more reporting, a lot more science. I will say that one of the things that is hopeful here is that I do think there is better, substantially better science on treatment modalities, on ways to help moms. I think this is one of the areas where there's a really it's really important, I think, to say, because we can easily veer into kind of hopelessness and burn it all down. The reality is that after all these decades, there is actually a ton of work that's been done that seems quite hopeful to me, and the health outcomes seem really strong. That's not to say that it's not going to be, a big public health challenge and a challenge for many of these families over time. But I think that is one area where we've made some progress. So that project, I think for my work on that will probably go public sometime at the end of summer.
Good, good. Yeah, I mean it's there's a wealth of science about having been involved in discussions around abatement and what we need to do, as well as the nature of the problems. The literature is vast in some of these instances, and so I think you make a fair point that there is science, that we do have science that can help support approaches to these matters. That's not to say that every question has been answered. Another participant has asked about your reporting on the epidemic and noting that you've covered a lot of different topics in a lot of different places. I mean, I think I said West Bank and Israel at one point, and
Hmm.
Ukraine is reporting on the opioid epidemic fundamentally different in any way? Does it draw upon a different part of your brain or require something different, or is it just sort of you're not in the West Bank, you're in rural Appalachia, but you're still digging around for stories and facts.
I think uh, there are times when in the darkest days, it did feel a little bit war zony.
Yeah,
And I say that sincerely. There were times
yeah,
when I would come out of, reporting trips and would need to really decompress in a very similar way. Not because bombs were going off, but because I was seeing people who I knew had a very limited chance of survival, right? We were in a point where, we weren't talking about long-term illness or typical addiction, related needs. We were talking about life or death. And I lost sources through those years. I still do occasionally, but at that time it was very, very intense, people who I cared
yeah,
about deeply.
yeah,
Um, and so I think that was and again, I do want to say it feels better now. That's just, some of the reporting suggests that that's factual, but it also, my gut is that it's not quite as raw. I will also say, just because it's important to say, is that covering people who are experiencing addiction is also, and this is not just politically correct kind of wokey stuff, it's also often joyful.
right.
People have shared, so much wisdom with me. There are times when I've learned incredible amounts where I've come home from a day in the field perfectly happy and feeling like I've met really cool people. So it's a complex world to go into. But some days it's really, really hard.
Yeah. I want to ask, I know we have many journalists that have joined us, and often one of the things that we think about at OIDA is sort of where are the stories that journalists want to tell?
Mhm.
What advice would you have for a young journalist that's trying to cut their teeth, knows maybe they have personal experience. Again, one doesn't have to go far to have been touched in some way directly, but they know they want to sort of write about the opioid epidemic, and they know that they're interested potentially in leveraging a resource such as OIDA, but they're not quite sure what to report on. Any thoughts for what advice you'd give them?
I do think one of the first things I would say is, have at least one leg of your stool in data, in documents, like OIDA or, some research paper, something. So much of the bad reporting on addiction that I see is untethered to that kind of grounding in science or grounding in some kind of documentary support, and things can spin out of control very quickly there. The second thing that I would say, and this came very slowly to me, this understanding, and many local journalists, many national journalists don't see this, and I think it's really damaging, is that addiction policy is often confused with public safety policy or quality of life policy, right? And those two things clearly overlap. There's a Venn diagram of people who are in severe addiction or disordered addiction and the quality of life in your community, or the people who are, you know, disruptive or whatever. And those are, you need to have both of those in your mind at the same time. And I think a lot of times people who are covering this topic um, mingle them or ignore one side of the equation or the other. They're both very important. But I think that's also, to answer your question directly, That's a really interesting, powerful way to tell these stories is to have somebody approach you and say, I have a story that I think you should do about a neighborhood that is experiencing some disruption or some lack of safety. And you can say, great, I want to start there, but I want to pull the story factually towards the public health side
Hmm.
and look at that intersection of issues. It can create really interesting, deeper, resonant storytelling. And it works the other way as well. Sometimes I'll have somebody come to me and they'll be like, I have this really great public health idea, this thing that we're doing, some harm reduction idea that's really cool and really interesting. But I say, okay, great, that's really interesting. But now I want to pull it over and see how is that affecting the larger community. This is an area, obviously, most of you on this group, joining today know this, but this is an area where addiction as a public health crisis differs so radically from diabetes or cancer or even COVID. Um,
Right.
there is this tension between the public disorder issue and the public health issue that I think we have to be very mindful of. The worst reporting that I see, and I see it almost daily, is people who are doing a public disorder story,
Hmm.
calling people zombies, talking about, people who are, disrupting a neighborhood, and they don't ever bring it into the public health space. And that's often very destructive, I think.
Yeah. There's a question about community organizations. I mean, you're speaking a little bit to this now, and I should say that we've had some interest. Well, two notes. So one, thank you for all of you submitting questions. We're the victim of our own success. We still have about 5 or 7 minutes with Brian, but Brian, if you're willing, I might ask for you to stay on after, just sort of in the background, but you would be able to address these questions, also the ones that don't get to, just by writing answers also
I'm
through
glad
the
to do it. I'll look through.
through the webinar function. They're great questions from all of you.
Great.
At OIDA, we've been thinking about geocoding documents, and there are there's millions of documents, 7 million documents, what did I say, 30 million pages or something, and many of them can be placed, actually reflect activities taking place in a particular region or location. It's really intrigued us, and it's something that we would like to pursue, resources permitting. But there's a question here about community organizations. I mentioned the geocoding sort of on the side,
Hmm.
but it is relevant potentially to local storytelling, and it's also relevant potentially to community organizations. I just wondered if you had thoughts about how community organizations might use the archive for their advocacy efforts. That's actually not my question. That's a question from someone who's joined us. How can community organizations use the archive for their advocacy efforts? And I just wondered if you had any thoughts about that. Let's assume that everything is perfectly geocoded, if that helps your answer at
Hmm.
all. I don't know, but if you think about how community organizations function, are there ways that you think these documents could be helpful to an organization working on, expanding addiction treatment in Albuquerque or something?
Yeah, I think I guess what I would say is this. The I think the kinds of documentation that exists in OIDA's archives and in some other places can give you a really interesting grounding in what companies have, what their strategies have been, how they've behaved, um, and patterns that might help organizations understand and communicate about what people um, facing addiction or advancing public health policy, what they're, going to face going forward. So I think that, any place in the country, if you're working on this stuff, it's worth diving in and doing some searching and some poking around to just see if there is an overlap. I do think one of the things, Caleb, that you're referencing in terms of doing geocoding, um, I guess what I would say is this. I think one of the challenges, obviously, with an archive of this magnitude is making it, is sort of finding ways to push information out, to give people, threads or teases. And this is important for community groups. It's also important, and I'm sorry to, to say this, but for many news organizations that have contracted in size and have shrunk, lost so much muscle memory and so much capacity.
Yeah.
I wonder how many of those folks at the Washington Post who just, absolutely broke the world wide open with their reporting are even still there. And so I do think that's one of the things that's going to be an interesting piece of OIDA's future, is to see what opportunities arise to help people grab things and string them out, and really tease them forward.
Yeah.
One of the other things I'll just mention in this context is that, anytime there's availability for more information in what is often an information conflict environment. Corporations, policymakers, they're constantly pushing out information. And so if you can dig into the facts and you can counter what might sometimes be misinformation or disinformation, I think that can be, very, very hopeful.
Yeah.
Yeah.
Thank you for those thoughts. And I should mention, at the risk of stating the obvious, and I'll state this at the close of the today's session, but OIDA is here to help for those of you that are interested in thinking about and living in a local community where you're interested in reporting or interested in trying to increase the relevance of your work, frankly, whether it's scientific or research oriented or journalistic. We're here to help. So please let us know how we can help. We are just about at time. I want to thank you again so much, and I want to come to a topic that I like to close with, which is one of hope. And you mentioned hope, and you said OIDA maybe has put a chink in the armor to this idea that things could be swept under the rug. And I just wondered, what gives you hope? There was a question, by the way, about how you thread the needle with the reductions in opioid overdoses that we've seen. How do you balance being hopeful in some of your coverage, yet acknowledging progress with the decrease in overdose deaths, while also not normalizing 60 to 70,000 deaths a year, quote unquote? So that was a question for you, but I just want to ask more broadly with that in mind. What gives you hope these days with respect to this matter?
Um, look, I do think that the facts bear out that public policy and public health are effective, when they're brought to bear. It's clumsy, it's slow. In this case, it was devastatingly slow, right? It took decades longer than it should have. It's difficult to think about what would have happened if the Justice Department had really come down hard and the DEA had really come down hard in the early 2000s, when they knew they had these documents, they had this information, they were seeing what we are now seeing. If they had responded, with more speed. But the hopeful piece is that over time, um, we have seen a slow turning towards more transparency. We've seen a turning towards more public health related policies, at least coming up closer to the criminal justice, responses. And I do think that while all of my reporting, leans into the idea that addiction remains a massive public health crisis in the United States, I do think that these reductions in mortality, and some of these improvements in health outcomes, are very, very significant. And I think there is a cost in our journalism, in our public debate. I think there is a cost in not keeping those facts in the foreground. I'll just say very briefly, one of the things that, as I reported it out, that was very, very shocking was the degree to which the Biden and Kamala Harris campaigns were incapable of talking about progress, during their campaigns. There was really significant progress, in, 2021, 2022, 2023, right into the campaign year of 2024, including huge progress on reduced mortality in many of the battleground states that were going to decide the election. And I mention that in this context because if some of those hopeful narratives had been factually just brought to the foreground, it might have been interesting for people to hear. And there's a consequence to that factual, hopeful information not being brought forward. We now have a new administration with radically different ideas about addiction and drug policy. And so I think keeping the facts in front of us and allowing hope in when appropriate, when the facts seem to bear it out, I think that's a really important thing to do. So, yeah, I think there's hopeful stuff out there. We're certainly not out of the woods yet, but this dramatic drop in deaths is worth celebrating.
Well, we're fortunate to have you, Brian, with us today, and fortunate to have you reporting, for our country. So, I thank you so much on behalf of all of OIDA and all of the participants. There's a whole host of questions waiting for you. So,
Okay, I'll answer some of them right now.
thank you so much for considering them. And with that, I'll hand things over to you, Pam. I thank all of you as our participants, and you're in great hands here with Pamela Ling, who again is a professor of medicine and director of the UCSF Center for Tobacco Control Research and Education. Thank you again.
Great. Thank you, Caleb, and thank you, Brian. Really interesting discussion, and really appreciate it. One of the things, Brian, that you said, mentioned is a tell, right, about the epidemic is that so much data is hard to get, and how there really is a need for real-time good data. And I think the audience will be happy to know that I think both of the speakers on the upcoming panel are really excited and inspired around good data and getting people good, useful data. So I'm going to introduce our first speaker, who is Ann Zink, Dr. Zink. She's an emergency medicine physician in Palmer, Alaska, and she served as Alaska's chief medical officer from 2019 to 2024, which meant she had to lead the state through the COVID pandemic. And she really drove numerous reforms that really made the health systems work better for people. She's also a senior fellow at the Yale School of Public Health, and she's a co-founder of pophive.org, which is an information platform that integrates de-identified health data to make it really accessible with the purpose of strengthening trust, improving situational awareness, and making actionable insights available to the people who need them most. I stalked Ann on her Instagram, and she does say that she herself is a mom, a wife, a lover of books, mountains, and health education, which to me sounds like an awesome combination. So Ann, the floor is yours. Welcome, and I'll have you take it away.
Great. Thanks so much, Pam. And thanks, Brian, for a great kind of keynote. And I'm loving seeing the questions coming in the chat box. Just going to share just a brief perspective and kind of building on some of the stuff that Brian had just previously talked about, but really looking forward to the conversation with Pam and Nav and with you all, because ultimately systems are created by us as people, and we get a choice to remake them and change them as we desire. And so it's really great to see the work that's being done. I'm going to go ahead and share my slides. Let me know if you can't see these okay. I decided to focus, there's some on data, and I'm going to talk a little bit about storytelling in the setting of data because as a practicing emergency medicine physician, as a public health official, as journalist, having information is incredibly important, not just having the data, but being able to share the information. I said I would never go into medicine. I was not interested in it, but I found myself working internationally and continued to find myself in health clinics where the impacts of not being healthy and well were just incredibly tangible and visible, and ultimately decided to go into medicine. Really debated. I was in inorganic chemistry and fine arts majors and debated a lot about what I wanted to do. But the imperfections of the emergency department is what I loved, that a patient's stories and experience really blended with the science and data. And we've talked already a lot about data. And one of the things that I really love about just the human experience is how challenging it can be to take that data to apply it to the human experience, and really how much information someone's lived experience really provides in moving forward. I chose to go into emergency medicine, but what I quickly found was that the emergency department is where all good public policy comes to fail. This may age me a little bit, but specifically speaking about opioids, when I was in my training and residency, I remember getting written up on my ortho rotation for not writing 150 oxycodones because that patient might then come back to the clinic and request more pain medication. And it was a time where we didn't really understand the harm of opioids. It's interesting to be training during this time and to look back in hindsight on how much we didn't know, how much culture, there was a real cultural bias that if you didn't you really just, it was important that you trusted someone's pain scale and that the treatment for that was opioids and opioids were completely safe. I mean, that was very much the training when I was training in the emergency department. Fast forward, I was a mountaineering guide. I moved up to Alaska for a whole bunch of personal reasons and came up there. And I remember coming up there and suddenly feeling like I was, I don't know, being asked to be a drug dealer. I felt like many of my patient interactions were, can you give me 5 more? Can you give me 10 more? After normal saline, the most common medication given in our emergency department was Dilaudid. And it felt uncomfortable. It felt as though we weren't doing something well, and you were seeing the addiction grow and change. And as a clinician, you knew something was wrong, but it was interesting. The data wasn't available or readily accessible. And I think, like in hindsight, yes, it was tucked within numerous places, but it was hard to access, and it just definitely was not the cultural experience. Um, this guy, Carl, he is okay with me sharing his name and picture, was a patient of ours in the emergency department at Matsu. And he came in a lot. He came in requesting pain medication. He'd initially got started on opioids from a doctor who'd prescribed them and then ended up turning to heroin. And really struggled with addiction for a long time. We all knew him in the emergency department, and he became clean and sober, and he became really angry. And Carl was like, "You all created my addiction. You need to change this." And we, as clinicians, were frustrated, felt like we needed to do something different. We're struggling to know what to do. And so we invited Carl to our doc meeting and we said, "Tell us about your experience." And it was a powerful meeting. I'll never forget. I can still remember it was probably maybe 17 years ago now, 16 years ago. I still remember like where he was sitting in the room. And he basically told us about the ways in which us writing for just a few more Percocets or a few more oxycodones when he broke his hand were ways that we fueled his addiction and we needed to do something different. And he was like, "You need to create a drug treatment rehab center. You need to create these different systems." And we were like, "Listen, we're just working in the emergency department. We don't have control over the whole hospital or the whole healthcare system." And he was like, "I don't have control over these things too." And so we decided that we should just work together. And if no one has power, maybe together we can have power and try to figure that out. And Carl is just an inspiration. He worked with us. In 1 year, we decreased opioids that were given in our emergency department by 90%. We decreased the opioids that were prescribed out of our emergency department by 70% in 3 years. At the same time, we increased patient satisfaction, continuing to give opioids for chronic pain conditions that were really key, not cutting people off right away, but also just really diving in and learning a lot about multimodal pain approach and other ways to address and treat pain. And Carl set up an entire system called True North Recovery. And so today in the emergency department, I can ask True North Recovery to come meet patients in my emergency department where peer-to-peer specialists with lived experience can come meet my patients in real time, sit beside them side by side and ask them, what they're ready for, what sort of treatment options they want. I feel like I actually have a lot more latitude to treat pain with a whole series of different tools that I didn't have back when I was first starting out in practice. And I have a whole series of tools to treat addiction in a way that I didn't as well. And so I oftentimes start presentations with the story of Carl. Fast forward, as mentioned, I became the chief medical officer for the state of Alaska and overseeing Medicaid and behavioral health and public health, and happened to be a worldwide pandemic during that time. And Carl and I would still go at it on, Medicaid reimbursement costs and the rest of it. And Carl and I still work together today. But I highlight this story as a story of hope and where patients, providers, policymakers, and where we can figure out ways to work together. And that really leads me to my next slide. I think through that story and through the experience with Carl and others, I realized that he was mad at us as providers, and we were really mad at policymakers that were rewarding us for making sure that patient satisfaction was critical. I think a lot of people were frustrated with patients, and I think that's a lot of stigma that you see throughout medicine. I wouldn't even just say it's opioid related, but obesity, vaccinations, people. I've never met a patient who wanted to be unhealthy, and I've never met a patient who wanted to go bankrupt. People are all making the best decisions they can within the systems and the construct that they come from. And so what I really realized was that if I wanted to make any changes within health systems, I couldn't ask just one part of this to move. I had to ask all of the levers. And so that included providers, policymakers, patients. And then I also really highlight the public and the press on here. So we just heard from Brian and the importance of storytelling and of the press, helping to change that narrative and understanding the perspective of patients, of people struggling with addiction, of providers, of policymakers can really help to kind of unlock the keys. And then the public, you think about what's happened with Mothers Against Drunk Driving. You see what's happening today with so many opioid task force and others that are making really important policy changes and systems changes. And so I would just say that public advocacy is a critical part. So whenever I get stuck on a health problem, I realize that it's because I haven't leveraged one of these five groups. I haven't involved patients in the conversation. I haven't involved providers to making a change. And so I always go back to this five. Turns out there's actually some data on why these can be really important five levers to making change, but it was something that I more kind of stumbled into. I kind of wanted to share a little bit of my perspective as a healthcare provider. When someone shows up in the emergency department, I have on the average 2.5 minutes with that patient. And I have to make decisions based on incredibly limited information. And I oftentimes feel like this is my experience. There is this patient behind this wall of experiences and information. And they have their medical history and medications and allergies and lived experience and lab results. And oftentimes I don't have access to that. Brian was just talking about the challenges of getting data on what's happening in opioids. I mean, it's so much even more than that. I joke about it as the two white pill phenomenon. People say, I take two white pills. And my computer system tells me nothing about what said two white pills you might be on for your hypertension or your diabetes or your pain. And so we've really made electronic medical records and information sharing a lot about billing, a lot about corporate metrics, but not a lot about the people behind it and the patient care. Fast forward to being a public health official. You remember I got this multi-million-dollar grant to address diabetes. I could see no information in the state of Alaska on diabetes outside of a survey that had been done 4 years ago if people had said that they were positive, that they had once been diagnosed with diabetes. So the lack of publicly available information to policymakers, to the public, is huge, and really appreciate the work that's being done here and trying to make sure that information, be it about corporate decisions, is available publicly so that we can make decisions together. And we know that a lot of what goes into our health is outside of direct healthcare. 80% of our health is determined by things outside of our healthcare system. So those are important data elements as well. If someone has a job, it's the single most important factor. And if they're going to be healthy or well, their physical environment, health behaviors all make a gigantic history. And I think about this all the time. This quote by Jonathan Hari, like, the opposite of addiction is not sobriety, the opposite of addiction is connection. And thinking back onto that last slide, this connection between all these other things, but also the connection between people and places that you're in. And then also the connection to your history and past. I put this slide in here highlighting ACEs, which many people are familiar with, adverse childhood experiences. And we know that when someone has had traumatic experiences in one's childhood, they have worse health outcomes across the board. So there's also this connection to our past that I think is really important to take into context. So when I'm thinking about data, I'm also thinking about over time, what happens, and I think about the trauma over time. And that becomes an increasingly important data point for me as a provider to think about someone's experience. If you haven't read The Deepest Well, I think it's a beautiful book about the impact of adverse childhood experiences. And we know that not just the rates of cardiovascular disease, respiratory disease, stroke, obesity, diabetes, but severe other outcomes, including 30 times higher rates of suicide attempt if someone's had 4 or more ACEs compared to no ACEs. Rates of addiction are all incredibly important. So I just add the time element in the ACEs study to highlight the importance of time in one's childhood experiences. And thinking about time, I think about systems in a very similar way that I think about people. Systems are built because of experiences, and we all get a chance to build the systems that we're in today. And, I don't think anyone would make the system that we have today for healthcare, but it is the system that we do have. There was this quote that I heard on Mother's Day the other day, saying, something along the lines of like, these are the good old days. Like the days that we're living in right now are the days in which history will reflect back on. And so what do we want to make of today? How can we take the documents of the past and the challenges of the present to make the future that we want? And this has really come to mind a lot thinking about the 1910 Flexner report. I've been really thinking about this report a lot more. It was an effort to really standardize medical care and to say we need evidence-based care, even though they didn't quite use those words. And they looked for a blueprint of like what was really good care. They ended up really kind of choosing Johns Hopkins and said, inpatient hospital care is where you really have amazing care, and we need to standardize medical education around this. It really built this amazing system of clinical diagnosis and of clinical care that has cured cancers and done transplants and amazing work. But it also completely separated out public health and healthcare. So it separated out community-wide care. It separated out things like adverse childhood experiences, jobs, the social environment, the connected environment. It closed the majority of the Black med schools. It made it much harder for women to get into med school. And so we had this turning point in our country in the 1910 Flexner Report. And we've seen throughout that time this history since then of the systems kind of being disconnected. And you see efforts kind of throughout the time, and I could put a million more things in this time frame of where we've tried to meld and try to bring back together these social experiences, public health, population health with the individual experience, to bring them kind of closer together. But I oftentimes feel like they're a wound that is tied together but continues to fray all the time at the edges. And I think we need to rebuild a system of health. So we don't have public health and healthcare, but we have a system of health and well-being where we're focused on what patients really need, what people really need to be healthy and well. And we have systems to support that instead of asking people to bridge the systems of this system of these broken systems. So you see like the Surgeon General's report for the first time instead of infectious disease focused on smoking in 1964. That was that kind of bridge. We're going to think about more than just infectious diseases. CDC was put together in 1946 really to address malaria, and that's why it's based in Atlanta. But then you see it really start to expand its focus, including, I'm going to fast forward to 2016, where it launched this initiative to say, what are causing deaths amongst Americans, and how can we build better initiatives to do that? You see efforts within payment systems within healthcare to pay for value or to pay for other services. Or I, brought the experience with Carl paying for peer-to-peer support services. You see in 2024, the rolling out of the HEAD model and health-related social needs is another way to kind of being able to try to pay for different systems. You see these kind of efforts to kind of undo some of the effects that we saw from the Flexner report and think more holistically. But I think that in these systems of healthcare is how we're really going to be able to build for a more holistic. It's not just about getting rid of the X waiver, but really treating people as whole people and thinking about how those systems are paid for. And we've been talking about data. I found as both a practicing physician and as a public health provider and as a health policy leader, I had so little data to make really good decisions on. And having great data is essential. And it's essential now, I think, more than ever before for a whole series of different ways. I do think that we're seeing real changes in the way that healthcare is paid for. And I mean, it's 18% of our GDP. It's keeping our teachers from getting paid. It's this huge slowing of the economy. And so there's a huge effort to say, like, how can we use the dollars that we have to be as healthy and well as possible? We have shrinking workforces across the board. The burnout is really real within public health, healthcare. I see nurses all the time leaving, physicians all the time leaving because of the burnout, and there's some real constraints in the training system making our shrinking workforce. Man, AI is here. AI is moving fast. AI is not well trained on a diversity of experiences. It's not well trained on stories. It's not well trained on healthcare in general, but it is making decisions. It's making decisions for individual people on a regular basis. And I personally think that we really need to lean in to make sure that the tools that we have, including AI tools, are the best that they can be. So again, that we can focus on people and patients and giving them the tools and resources they need to be healthy and well. As mentioned, new care models demanded, and Brian mentioned this about mistrust in organizations and systems. And I personally don't feel like, a campaign to say, trust your doctor is useful or trust your public health provider what's useful is creating FOMO, creating tools and resources that are so useful, people want to use them. And when they use them, they are healthy and well, and they have the support systems that they need. And I think that that's what's really exciting about just, this series of documents. I saw questions in the chat box before about like, how can people use this? This is past. Why is this not there? And I think about how many implications there have been from the opioid epidemic. Pharmacists hesitant to write for additional scripts. There was a comment about why aren't more providers writing for MAT? I think stigma is part of it, but part of it is also like we were trained to not write, to write for opioids and then figured out the harm associated with them. And so I think there is the stories and there's the data, but then there's also the lived experience. And so I think understanding how industry works, how policymakers work, how systems work is an important data point in understanding what are the systems that we have and how can we collectively change these systems to move things around. I won't dive into this a ton, but I'm happy to talk a lot about this. It's what I talk about most of the times. But in my frustration and not having good data, we released this tool out of Yale. It's a free, publicly available tool called PopHive, standing for Population Health Visualization and Information. And the idea behind it, you can play around with it. You can go through it today. You can look at there is actually injury and overdose information up there now. So sorry, this slide's a little bit older. But on there, we try to pull together publicly available data sets, but we're also very involved in trying to make sure data sets that have not been publicly available are. So we have a working relationship with Epic Cosmos, which is the country's biggest electronic medical record, to being able to put out data. We work with other tools such as the crisis line to make sure that de-identified trends can be shared to understand where people are struggling. And we're always looking for partners to share on what sort of data is out there. This can also be ingested by AI. We're working with different AI companies so they can sit on top of it so you can easily access it. And our goal isn't to tell the story of what someone should or shouldn't do, much like these archive documents, but just providing the data that's out there so that you as journalists, as healthcare providers, as patients can decide on what are the best steps moving forward. And I kind of go to three core principles that I always think in terms of data and what is needed in this space. Trying to collect data once, but use it multiple times. I mean, how many times have we all filled out that same form when we go into a healthcare provider's office or trying to recreate the wheel? We don't ask that of our phone and of so many other informations. Making sure that health data is in the hands of patients. They are the number one driver and advocate for their health, and they deserve their data and their information. But we must have publicly available population health data. This is de-identified, can't not identify a person. But if we're going to make policy decisions, if the press are going to report on what's needed, we have to have publicly available public health data as a whole. Because when we think about the risk, it's a combination of the probability of something happening times the consequence. But that requires data to know what the consequences are of different actions and to also know the prevalence of what's happening. And I think that I just wanted to, highlight on a few last things. I think a lot about this in terms of the continuum of communication. What I need as a clinician is actually quite different than what I need as a public health official, which is somewhat different than what I need as a press. Because we all have a little bit different metrics within what we need. Scientists are really here to think about just what is the data, and there's going to be huge limitations of what that looks like. Versus clinicians take that information and try to apply it to a patient. But as a public health official, I try to apply that to a whole group of people. So I don't know their history, I don't know their lived experience, but trying to apply it to a larger population. Versus the press is trying to tell a story, to take that data information and to put it together a story, which is very different than the lawyers who are trying to pick and choose data points to make a point. And so I just highlight this continuum of communication so that we don't expect scientists to be lawyers and we don't expect lawyers to be scientists, but we realize that they all have a valuable role within it, but putting the information and data they share into context, because I think that's really important. So just a few last thoughts. This was one of my favorite articles during COVID. As mentioned, I led during that time in the state, but Alaska's remote villages, a race against time and history. And I think one of the greatest gifts that I was given was the history of Alaska Native elders telling me about the 1918 pandemic. The hospital in Dillingham is built in the orphanage that was created out of that pandemic. And we talked about with Brian about memorials and making sure we remember history. Being able to learn from the history of Alaska Native people on previous bad pandemics was incredibly important. And I hope that we're able to learn from the history of the opioid epidemic so that we're able to not recreate the mistakes of our past. And that when we face future challenges and as we face challenges today, we're able to be able to take that history and being able to apply it moving forward. Because I think one of the greatest gifts I was given was the wisdom of generations, being able to share their experiences of the Great Death and the ways that we can apply that. And I hope that we're able to take the history that we've learned from the past and move it forward. I think that authenticity is incredibly important as we move forward, that we find ways to make things local, that we don't just tell, like, here are the numbers, but we show stories. We put them into context and we realize that those contexts matter. In a new world of AI, things change fast, and this reality of what is reality and not is going to be incredibly important. And how we think about publications is really going to matter. And are these storytellers? Are these on our social media? Are these the TikTok that my daughter's listening to? Because at the end of the day, I think we have to think about what's right for patients and remember that the rest is noise. So thanks for the opportunity to share some thoughts, and back to you, Pam.
Thank you so much, Anne. That was amazing. Lots of things to think about. And we're going to have our second presenter, and then we'll have some time for discussion and questions. Really lots of things to think about. I'm going to move us along to our next speaker, who is Dr. Nab Dasgupta. And we're excited to have you here. Nab is an innovation fellow at the University of North Carolina Gilling School of Public Health, and he's an epidemiologist and harm reduction advocate who combines scientific studies with community engagement to improve the safety and well-being of people who use drugs and people living with debilitating pain. And he's had a particular focus on overdose prevention. He's worked to increase access to naloxone and developed a national drug checking program for unregulated substances that I think we'll hear about today. He won a MacArthur Genius Grant Fellowship. He wanted one thing, he's a Genius Grant. And his LinkedIn says that his passion is telling true stories about health with numbers. So I think that aligns really well with the message today. And Nab, the floor is yours.
Great. Thank you so much, Pam. And thank you to Brian, Anne, and Caleb for setting the scene for this last bit. We are at a multi-generational inflection point now in the opioid crisis. And if you're sitting in your office, I want you to do this little ritual with me. If you find a paperclip that you have handy that you can sacrifice for this purpose, grab it. I can show you what the last 50 years of overdose deaths look like in the United States with this paperclip. You bend it a couple times. And this is a particularly tough paperclip, but here we go. So this is the curve of the opioid overdose crisis in the United States. 50 years. So this is the number of overdose deaths, and this is time from about 1976 to 2026. And what we have is kind of an increase in overdose deaths: Valium, Quaaludes, heroin, crack, heroin again. Then we get into extended release opioids. We get into methadone for pain. We get into prescription opioids. We get into heroin, fentanyl analogs. And then this real substantial increase is illicit fentanyl. And this really kind of started around 2016 and then really took off during the COVID pandemic era, which is this part right through here. 2023, we started seeing this come down. Now, where we are now, what we often celebrate or are at least optimistic about is this 30% decline in overdose deaths. But what we often don't talk about is this is a 4x increase in overdose deaths in our society over the last 50 years. So let me show you that. Let me show you what the actual data look like on this. So that's a pretty good estimate, isn't it? So this is something that you can keep on your desk to remind you of how far we have come in a positive direction, how far we have left to go. So the slides are already available via this QR code. Just to be clear about funding disclosures, because I think it's exceptionally relevant in this environment. I'm funded by foundations and nonprofits. We have funding from the North Carolina General Assembly through opioid settlement funds. Our research projects are funded by the U.S. Food and Drug Administration. The drug analysis project that I'll talk about is done free or at cost. And I'm also on the board of Remedy Alliance for the People, which provides bulk naloxone distribution to public health programs free or at cost. Okay, so I work at the Opioid Data Lab, and the Opioid Data Lab is a collaboration between the University of Kentucky and the University of North Carolina in Chapel Hill. At the Opioid Data Lab, our projects are divided into three categories: theory, practice, and lived experience. The theory projects are super nerdy, and they're kind of fun. I love them, like biostatistics methods and epi methods, the psychology of how we communicate drug alerts, and the pharmacology of these basic molecules. The practice projects are applied research often asked of us to do by government agencies that really look at the practice of pharmacy, medicine, vital statistics, how we count overdose deaths. The lived experience projects are the most interesting, I think, and they include the drug analysis that you'll see in a second, but also field work that we do, qualitative interviews, and historical projects. Like Pam said, one of my passions is telling true stories about health with numbers. So today I'm going to give you some specific examples, a bit of the toolkit that I use to talk about health with numbers. You saw a performance piece and a ritual. Things like that matter to help bring communities together. I'll also talk about low barrier ways to give people back data who need the data first. I'll show you examples of how overlaying historical data with other forms of historical data can show you discrepancies that are happening today, and then I'll give you a relatable analogy as another storytelling tool, and finally, kind of show you an example of an even older document archive that is related to opioids and mental health that we are trying to work on at UNC to make relevant in the current context. So first, right now, this is a multi-generational moment. We have seen, so back in 1946 in North Carolina, tobacco was celebrated, right? And this is the Farmers Federation Tobacco Queen in Asheville. This is across the street from the State Farmers Market a few months ago. These are old cigarette, not vending machines, but like display cases that have gone out of commission because those products are no longer being used at the same rate. The point is that drug tastes change across generations. And one way to look at this, specifically with fentanyl, is to see the median age of who's dying from an overdose and how that's changed over the last 25 years. So initially, through about 2014, most of the fentanyl overdose deaths were a fairly low number. No number is really too low. But up to about 3,000 a year, and those were from prescription opioids, particularly transdermal formulations and ultra-fast oral formulations. What happened in 2014 was the entrance of illicit fentanyl into the street drug market. And what we saw was a distinct shift from the baby boom generation to Gen X using those opioids. Illicit opioids, particularly fentanyl. And then we saw that kind of as we moved into the kind of peak of the paperclip that you saw before, that was largely kind of split evenly between Gen X and millennials. What you see now is a further shift between millennials and Gen X. Here's the key number to remember: 70% of overdose deaths are currently happening among Gen X and millennials. Now, that is something that surprised me. Well, let me show you the data. So this is my hand-drawn version of a real graph that you'll see in a moment. On the vertical axis will be the number of overdose deaths in the United States. Along the horizontal axis will be time, and it's year of birth. So younger will be on the right and older will be on the left. You'll see two humps in there. You actually see three, but just focus on the two major ones, which is 2022 versus 2024. So this is where the reduction in overdose deaths are happening the most. All right. So what we have going on right now is three things at the same time. We see people who are older aging out of illicit opioid use. We have people who are using in less risky ways and being more apt to go and seek treatment. And most importantly, we see fewer younger people starting illicit opioid use. So bringing these together into the actual data, what you see is that graph, right? And what we've done here is impose the generations by year of birth of of the birth cohort generations. And you can see again that millennials are and Gen X are kind of bearing the brunt of overdose deaths. So particularly people born between 1975 and 1985. And we also see that Gen Z has much lower overdose death rates than their parents or their grandparents or even their great grandparents' generation, given how long this crisis has been going on. Part of the reason, is maybe education and awareness, but I think this number is also super deep to really contemplate. There's about 1.5 million children who have lost a family member to an overdose, a direct family member. And yes, we think of parents, but it is also aunts and uncles and grandparents. And so when we talk to our advertising colleagues about what messaging works in health, one of the things they point out is that messaging can only take you so far. They can't really change people's minds whose minds don't want to be changed. What I can promise you is that if you're sitting in the front pew of a church in an uncomfortable frock, listening to a eulogy about your aunt, that experience is going to sear more deeply into your subconscious as a negative reason, as a negative example of why not to get involved in prescription opioids, street opioids, or illicit drugs in general. And I think this is part of what we don't capitalize on in our public health campaigns. And here's where the data actually start coming into play. The state of Maine, where I grew up, has one of the fastest and most accurate overdose death reporting systems in the country. It's been 11 months since anyone under age 25 died of an unintentional overdose in Maine. That's zero. We haven't heard numbers like zero in a really long time. And that's why I think what is happening now is a unique inflection point where if we keep going and working where the bulk of mortality is and preventing new initiates, we may just have a chance to bend the curve on this on the opioid problem in the United States. So the second thing I'll talk about is to show an example of how we use our drug analysis data to provide data back to individuals quick enough for them to make decisions about what they put in their bodies. So synthetic soup is the way we think about and talk about what is actually in the drug supply. So we get our drug samples mailed to us in this kit. The kit looks like this, and you can see Stephanie holding up that kit there. And where these kits came from was actually, since Anne was mentioning COVID quite a bit, and so did Brian, when I was early before there were the swab kits for home testing, I was sitting in a drive-through for a COVID nasal swab, and there was a vial in there with a bit of liquid and a swab, and you could fill out a QR code and get this sent off and get results the next day. And I thought, well, if we can do this with COVID, why can't we do this with dope? And so that is the origins of our drug checking program. So we get the samples from health departments, clinics, EMS teams, harm reduction programs from all over the country. Our program has 3 rules. This is Ainsley Bryce in the Western Mountains of North Carolina, kind of showing you how it's done in practice. So the samples have to be provided voluntarily. The tests have to be anonymous to us. We know that the programs know their clients, and we work directly with the programs exclusively. And the results must be returned to the sample donor in a reasonable amount of time. The packages arrive on campus in compliance with all drug postal laws, drug and controlled substance and postal laws. And this is legal in all 50 states and territories. We use GCMS to do untargeted search to figure out exactly what's in the drug samples. To date, as of last week, we've tested about 21,000 drug samples from 44 states, which gives us not a perfect view, not a complete view of the drug supply, but pretty good for understanding patterns in fairly real time. The most important thing we do is give results back to individuals. And inside this kit, there is this QR code with a sample number that goes to the website. People can get the results, no cookies, no logins, nothing like that. So what do people do with this information? So part of what we've done with this information flow is turned the usual public health surveillance system on its head. The people who provided the donor of the sample, the one who is most directly impacted by that drug substance, gets to know the information first. The program that serves them gets to know it about the same time. Anything we do beyond that is looking at trends and patterns is for policymakers, public health professionals, clinicians, and those are aggregated data. And so we're not starting from having a ton of data that we're trying to disseminate to people who need it, but rather we're starting by giving the information back to the person who needed it, which is exactly the lesson we learned during COVID and taking these tests ourselves. So what has this kind of shifted paradigm allowed to happen? Well, it's been a form of citizen science that's been super cool to watch. So these are some of the questions that community groups have actually used our kits to answer. So is there fentanyl in the black tar heroin? Are nitazines causing these overdoses? We have patient clinics that send us, hospitals and clinics that send us samples when panels come back negative for the finite set of drugs that the clinical labs are testing for. All these great questions, and some of them and none of these were things that we initially expected to happen. We were like, okay, maybe, but these are all questions that community members came up with themselves because this was the information they needed to be able to act in their local communities. And sometimes we got questions that were really unexpected, like what killed my husband? We get samples from widows. They swab the pipes and say, my husband only smoked meth. Why are they saying that he died of a fentanyl overdose? And while our medical examiner system in North Carolina is awesome and I have the highest respect for them, some of these widows need closure sooner. So the emotional aspect of doing the science is really way deeper when you let go of the control of how the data are used and how the tools are used, and you get people making really important inferences for themselves and for their own communities. We do use advanced statistics, a lot of AI, and we make our data public daily. And you can see on our website, opioiddata.org, if you click on data, you'll see all our live reports that are pulling directly from our lab database as samples come off the machine. One of the patterns, and this is the only kind of data pattern I'm going to show you in the last few years that I think is fascinating, is that when you buy a bag of fentanyl, it's becoming less likely that that bag actually contains any fentanyl in it. So in 2023, in our samples, it was about 86%, dropping to about 77%, and then close to 20% into 2026. In places like Pittsburgh, that number is 60%. So 4 out of 10 times when someone says that they bought fentanyl, used fentanyl, they actually did not have any fentanyl exposure from that bag. And so the question is, what's happening? What is replacing fentanyl and why is that happening? So here's another kind of tool that we use in telling stories about data, is to kind of bring it into terms that a broader audience can understand. So shrinkflation is a broader phenomenon in our society. What do you do when you have less of the main ingredient? So I'm going to give you an example from one of my favorite drugs. It is a combination of theobromine, caffeine, phenylethylamine, and anandamide. And as some of you may have guessed, this is chocolate. So what happened in 2025 is that there was drought in the Western African countries that produce the chocolate beans that are used in making candy bars in the United States and in North America and in Europe. And because this is a regulated product, you can subtly see that Mr. Goodbar is no longer called milk chocolate with peanuts, but rather chocolate candy with peanuts. And so there's these subtle things that are actually real. So what's happening when there's less of the raw material? Well, it's being replaced with more vegetable oils, more sugar, and more nuts. So what we have now is a drug supply that is more fentanyl-flavored sedatives in a lot of places, especially like Pittsburgh. We can see the same thing happening with ice cream, and summer's here almost, right? And if you look carefully, you'll notice that a lot of times it doesn't even say ice cream anymore. It says dairy dessert. And you can see the same substitution effect happening. Well, we see that same substitution effect in the street drug supply. And these are the top adulterants of fentanyl that we see in our samples. And the number one adulterant are local anesthetics. So Novocaine, like you get at the dentist, lidocaine, procaine, tetracaine are the three. So those are even more common than xylazine or medetomidine, bromozolam, or nitazines. And so I think, trying to normally we would go into these in more detail, but as like a capsule story here, this is kind of the way we kind of talk about it. I'll close with an example of a even deeper, or not necessarily deeper, but an older archive. These are asylum documents that have been digitized in North Carolina from 1856 to 1922. And this is the process. You can see some of the intake ledgers of doing that, taking this beautiful cursive writing and running it through machines that can read old cursive was a specialized AI tool that we had to train. But we've been able to compile together thousands and thousands of records, so admission ledgers, not just from the asylum to serve white folks, but also for the colored insane, which is what Cherry Hospital was called at the time. We have general case books, staff interviews, and lunacy commission commitment papers. And so and we have a huge archive of news articles going back to this historical period. And so how do we make something this old relevant to right now? Well, one way is to look at it in terms of quantitative numbers. And this is the number of opiate admissions at Dix Asylum in Raleigh from the 1860s through the 1920s, almost to the 1920. And what you see are these like two particular spikes. And it turns out that nearly all patients admitted for opiates to the asylum were pharmacists, particularly, or healthcare professionals, particularly pharmacists. And those were 2 years when new opioid patent medicines were released and became popular in this niche group of professionals, and then they went to get help. So that's one way to look at those historical data. Another way is to combine it with other historical data sets, such as redlining in the South, which is a way of excluding home ownership among minority communities. And the dots here represent kind of where people were declared insane and brought against their will and brought into the prison of the asylum. And in the places that were of higher value, those neighborhoods were largely spared. And the concentrations are really in the places that where minorities lived. I'll close with this example of how we can make this relevant for today. So involuntary commitment is being proposed as a solution to the kind of overdose problem that still lingers today. But the 1966, there's a Supreme Court case which established that substance use disorders are not a criminal offense. And this was the Joe B. Driver case. And Driver was a repeat patient at Dick's Asylum and was arrested hundreds of times for public drunkenness. And so what they're doing as a school project at UNC is to tell his full story, kind of linking it to the jurisprudence, but also to the legacy of involuntary commitment that is rearing its ugly head today and kind of not forgetting what has happened in the past. I'll skip today's bad actors, but I will point out that there are a lot of, well, I'll just say really quickly, there's always someone looking for a buck. We saw this with the prescription opioids, and we see similar things happening now with solutions to the opioid overdose problem. And we should be very careful about these. The Opioid Policy Institute has a great website that tracks these by state, and you should check it out. That's the website there. My final thoughts are that we should always be asking who needs to know the information first. And that's usually the person most directly impacted. If we blend data, historical records, and narratives, we can tell stories that stick. And we need to make sure that stigmatized topics are salient by connecting with audiences through their everyday experiences, like eating chocolate. And we can make that all tangible through authentic experiences that transcend the screen. This is our newsletter via the QR code. Please sign up. And this is our awesome team. Thanks.
Great. Thank you, Nab. Thank you. Amazing. So many good things to think about. I feel like we only have about 7 minutes or so for questions. But I wanted to pose a question to both of you, since you've obviously done some deep thinking about data and making it useful to the public and releasing. So I'm curious of how do lessons that you've learned from working with your data, what advice would you have to the opioid documents library in terms on how to maximize the impact of the archive?
I'm happy to dive in. And I think that there's so much there. I really love Nab's comment of like who needs the information first. So I think thinking about who your end user is and how to make that easy and accessible. There's a saying in emergency medicine, like, there's only like 5 clicks and you can't get to the space that you need to do. So using AI, I love the way that you guys already like analyze it and be able to break it down. But I think thinking about even working with AI to build skills so that if you're like, I'm a someone who's struggling with chronic pain, or I'm a policymaker, or I'm a researcher, that you can more quickly access the information that is readily available so that you're able to put that information into action. So I think to Now's point, the end utilizer comes first, who needs to know that information first, and then building out the tools to make sure that you're answering their questions as quickly as possible would be my thoughts. But now over to you.
Yeah, I think you summarized it perfectly. Kind of thinking through who are the different audiences for the information, and making subsets, pages, extracts of the total corpus that might be most relevant for individuals, whether that's geographically or by profession.
Awesome. And both of you have talked a little bit about history and done some, illustrations of things from history. And certainly there's a little bit of, people will sometimes dismiss archives and just say, well, that's old stuff from the past. And, now we're, don't focus on that. We're moving forward in the future. Can you, how would you answer this kind of question of like, why does history matter? And, and how has that impacted your work?
I mean, I'll start with the asylum project was really eye-opening to me, and it's the narratives. There are kind of historical, sociological kind of stories of following one individual throughout their life course at the asylum, and some of the language is nearly identical. Like the graph that I showed you with the opioid admissions, we use the same code that we use for ED admissions to hospitals from syndromic surveillance data today to analyze the data. So it's not really, things really haven't changed as much as we think they have in a lot of ways.
I would echo that. We didn't plan our presentations, but it was great to see the history kind of reflected differently. I think, in sharing like the home sampling and the home testing and like how we can learn from history and apply it to other things. We saw during opioids that some of our native villages actually hired people to test everything that was coming into the community to make sure opioids weren't coming into the community. And that really substantially decreased the amount of opioid deaths in community. And we basically built on that during COVID. So we would test at airports to try to prevent COVID from entering into the community. So I think that there's so much lessons and deep knowledge within these documents that apply well outside of even the opioid epidemic that I think are important for just everyone to think about. How does industry and society and policymakers be able to fit together? During COVID, I can't tell you, I think I read it 3 times, maybe 4. I reread The Great Influenza, and I was so grateful that someone had like taken the time to write that book. And it was so much more helpful than even you know, like how many cycle scan thresholds you need for a PCR testing, because the reality is like as humans we're very human in the way that we respond to things, and there were so many lessons learned from the great influenza that was incredibly useful before. So I just really appreciate the work you've put into this so that we can not only not repeat the past, but not rhyme with the past, be able to have these experiences and being able to see them, learn from them, and take lessons learned and apply them more quickly.
And then you guys have both talked about working with communities. I loved, Nab, the kind of the questions, right, that came out of the citizen science. And then you've also talked about like really having powerful learning experiences and working with community members. I'm wondering if you might think a little bit about, I feel like our archives are like, we sort of say we've got 7 million documents, 30 million pages, go for it, right? It's not the most kind of, how can we sort of integrate kind of community-driven questions, right? Or make more connection between the kind of questions folks in the community have and the archives.
I would love to see layers be built on top of it. I think a lot about Project Stethoscope that has been built out in California, which is using, honestly, AI to listen to Reddit conversations and forums and what's happening in people's conversations, so that not only forums like this, but that we're using technology to hear and listen loudly to what questions people are asking, and then being able to connect that to the data and information that's there. So if people are like, I want to know, like, why did, like, to Nev's point, like, why did my spouse die? Like, what's circulating in my community? I had a journalist the other day who said, unfortunately, her brother had just died of an opioid overdose. And she's like, all I hear is the numbers are going down. But when she looked at her Pop5 data, the numbers in her state with her brother's age population have actually been going up. And so being able to hear what people are saying and then connect them to data, I think is a really powerful way for change. And so by her being able to see that reflected in our data set, she was able to then connect with her policymakers and the rest of it. So listening loudly to what the community and what people want, and then connecting that to the data and information that's out there would be my suggestion or thoughts.
That's a great example. I'm glad that was impactful for them. Context is so hugely important. I think one place where the opioid archive can help is there are so many counties that are working on opioid settlement funds, and for them, kind of the arc of the story goes back like all these decades, right? And sometimes they're left with the impression that there's still like prescription opioids are the biggest driver of overdose death because of the legacy of where the money came from. I think kind of using the archive in its historical context, I think could be could be a way to help them focus on here's what the current, here's what the history was, here's the evolution, and here's the current problem. Because right now that's a bit of a jumble when I go to opioid settlement meetings at a county level.
Awesome. really so grateful for you guys for bringing your experience and insight to the forum today. We're at 10:55, and I have been told that is the time for me to throw it back to Caleb and to close us out.
Great. Well, thank you so much. Thank you, Brian, again, and thank you, Anne and Nab and Pam. And I want to also, again, thank Kevin Hawkins and Amanda Norman and Kate Tasker and the full OIDA team that spans UCSF and Hopkins. You know who you are, and we appreciate you. And I'd like to also thank each of you for joining today. Brian made a point today that I want to sit with just for a moment, which is that the historic secrecy that's governed massive multi-district litigation settlements has not been incidental. It's been structural. It's been a standard practice. And so the default has been historically that documents produced during legal discovery for major public health crises, such as the opioid epidemic, typically have not seen the light of day. And OIDA exists because in this instance, that default has been overturned case by case through the work of plaintiffs, attorneys general, the courts, and other parties who've insisted on transparency as a condition of accountability. And today's also reminded us how much remains to be discovered in the collection and how OIDA can serve as a platform to drive societal change, whether as a means of supporting local journalism, or demonstrating the role of powerful corporate actors in shaping the determinants, the commercial determinants of health, or to shape the legal and regulatory and policy and public health frameworks that may help to head off the next crisis before it arrives. There was Nab, you and Pam and Anne were talking about sort of looking back to look forwards and there's a famous quote from Shakespeare that what's past is prologue from The Tempest, which reminds us that history sets the context and foundation and stage for the present and future. So that's the work. The archive is here for all. It's 7 million documents plus 33 million pages, freely available. That's a lot of documents, and we're aware of that. And there are many, many resources that are available for exploring and teaching and mining the collection. And those range from small curated document sets to curricular materials to numerous what we call story guides that provide concrete hooks with supporting documentation to an image collection that provides a visual entry point into the archives. We also have world-class archivists to support your engagement. So reach out to us. I'm providing here information about how you can find us. We also hope you'll join for the rest of the symposium this week. So tomorrow, Wednesday, May 13th, from noon to 2 p.m. Eastern, we'll explore how AI and other technologies are changing what's possible for managing and providing access to massive digital collections like OIDA. And then on Thursday, May 14th, also from noon to 2 p.m. Eastern, there's a terrific interdisciplinary panel that will look at how OIDA's collections can help us tell new stories and develop new analyses, looking back at the worst drug epidemic in U.S. history, and again, looking forward. So these 7 million documents are really a beginning, not an ending. And we thank you again for being part of this work going forward. This marks the conclusion to today's events. Thank you again.